So thank you very much for asking me to speak about stigma and discrimination this afternoon. Actually, a lot of what I'm going to tell you has been culled from a series of workshops we've had globally, really, in Asia, South America, Europe, really trying to examine where we are with stigma and discrimination. So I'd start off by asking you, what is stigma? And of course, the best way of looking at any definition is to look in the dictionary. This is the Oxford English Dictionary definition of stigma. It's defined as a mark or a token of infamy, of disgrace or reproach. It's a mark indicative of the history of disease or abnormality. So we get the gist that stigma is something which really isn't very nice. And of course, stigma is really, really complex. It's based not on an act always, but more of an idea, a thought that an individual has, which is usually based on prejudice, which they have learnt. It's something which discredits people. It discredits people in the eyes of others. And there are two main types of stigma which we can look at. First of all, external stigma, the experience of being treated as different from other people and the effects that has on the individual and indeed on society. But more and more, we're recognizing the idea of internal stigma. It's almost a self-stigmatization, the way that a person feels about themselves because of what they perceive or because of what others have told them, a feeling of shame, of rejection, of discrimination. And at a recent meeting, actually held by Gilead, individuals who were healthcare professionals were asked what was their definition of stigma. And you can see there's a whole variety of different feelings about what stigma is. But perhaps most importantly, when we talk about stigma, it's actually, we should be talking about me and you. It is society, and that is me and you, who does the stigmatization. We aren't born learning how to stigmatize. We are born actually without that knowledge. It's something that we learn from society, from our peers. And so it's up to us all to really do away from stigma, not only in HIV, but in other diseases and again, other facets which we see in life. And of course, sexually transmitted diseases have always been stigmatized. You can go back to 1492, when Columbus went and discovered America, the island of Hispaniola, and brought with him influenza, measles, smallpox, TB, and gonorrhea, leading to the death of 8 million in that society. But of course, Columbus also brought syphilis back to Europe, a really big epidemic of sexually transmitted disease. And with that came stigmatization. It came with blame. So the French called it the Italian disease. The Italians called it the French disease. For once, the Germans and the British agreed with the Italians and blamed the French. And every society blamed another. The Russians, the Poles, the Germans, the Dutch, the Spanish, the Portuguese, the Spanish, the Japanese, the Portuguese. And it was only the Spanish who didn't actually have a name based on an area or country, which stigmatized this disease as being something abnormal, something to be blamed upon others. And we've seen exactly the same with COVID, with the coronavirus and stigmatization of individuals of Asian origin. And of course, HIV has always been associated with stigma. You only have to go back to the very early days of the epidemic, 1984. And of course, we're not in 1984 anymore. But stigma remains. If you look at the early days of the epidemic, this was the kind of headline you saw in the paper. Wife murders hubby with AIDS cocktail. AIDS is the wrath of God, says vicar. Britain threatened by gay virus plague. But if we come to the modern day, which is now almost 30 years later, we remain, over 30 years later, we remain stigmatizing individuals. This is recent data that came out from the UN AIDS showing the high rates of discriminatory attitudes which people living with HIV continue to receive throughout the world. And of course, countries stigmatize individuals with HIV. They treat them as being abnormal, something which is different. There are still countries that deport non-nationals based on their HIV status. Countries and territories that prohibit short and long-term stay on the basis of HIV treatment. Countries that require HIV testing or disclosure to allow certain types of entry. And if we look at the burden of stigma in HIV disease in key populations, it remains at a high level. And it's amazing that within, with the last 40 years of the epidemic, this high rates of stigmatization remain. And that stigmatization is also felt among healthcare professionals as a key barrier to individuals being tested and accessing treatment, particularly in people who use intravenous drugs, in MSM, and in sex workers. So what can we actually do about it? What can you do in your daily practice to actually reduce stigmatization in HIV? And I'd like to look very briefly at two things that we can all do. First of all, we can spread knowledge. It's amazing the lack of knowledge in healthcare professionals. This is a recent survey done in the United Kingdom looking at healthcare professionals and knowledge of HIV. They surveyed doctors, nurses, other healthcare professionals. 80% had not heard of U equals U. 35% still believed that it was not possible for an HIV individual to conceive and deliver an HIV negative child. 38% thought that treating an HIV-infected individual put them at risk of HIV. And 47% believed they would acquire HIV from a needle stick from somebody with an undetectable viral load. When was this survey done? Early 2000s? No, 2020. This is the kind of knowledge that we need to continue to spread. We need to teach our peers about this, remove some of the fears. And it's amazing, how people act. I'll tell you a story about an individual who worked as a surgeon at this hospital, now retired. One of my patients went to see him about her thyroid, and she had, I think, an overactive thyroid and required operative intervention. And the surgeon said to her, why do you want to have your thyroid removed? There are other treatments. She said, well, I was told this was the best way to have a child. And he looked aghast and said to her, there's a place for women like you, and that is called hell. Isn't that amazing? This is an educated individual stating this to someone living with a long-term, chronic, but treatable disease. The second thing we need to look at is the way that we utilize language. And I think there's this great idea of this status-neutral approach in HIV. This is from Dr. Pranafakt, who presented this at our Asian Stigma workshop. But the idea is that nowadays, there should be zero risk of transmitting HIV. We all know about U equals U, even though our peers don't, and that leads to a zero risk of transmitting HIV. We're all aware that PrEP works. As long as people take their PrEP, it seems to work almost 100% of the time, and therefore there should be a negligible or no risk of acquiring HIV. But when we come and look at U equals U, U equals U remains stigmatizing. It's a sexual stigma because with U equals U, condoms are no longer required. There are concerns about sexual risk compensation, that people actually will be having more sex without condoms and therefore a greater risk of acquiring HIV. Although we know that U equals U means no risk of acquiring HIV. There is this lack of knowledge and disbelief. There are stigmatizing attitudes towards individuals related to so-called sexual irresponsibility by not using condoms. And this is particularly so in those minority groups who are already stigmatized because of their non-conformance to gender or what is considered in some societies to normal sexual practice. So as providers, it's important that we discuss U equals U in an appropriate way because individuals still query it. Individuals still query it. They say nothing carries zero risk. They're skeptical about it. They never say never. And even pharmaceutical companies are causing issues by saying, oh, you need 3 drugs, not 2 drugs. It's nothing to do with that. It's about undetectable viral load equals zero risk Not nearly zero risk or almost no risk, zero risk. Our use of language is really, really important. And the same with PrEP. PrEP again carries sexual stigma for the same ideas that by using PrEP, you're going to be having more unsafe sex, a greater risk of acquiring HIV. It's not fitting into what society expects, or shall we say, society expects as normality. And hopefully that will change. Clearly, before PrEP, people were using condoms. They were having limited sexual partners. And with PrEP, it allows them more sexual freedom, but really a return to normal sexual freedom. But the way that we give out PrEP is very difficult as regards language. We talk about, and many guidelines talk about, PrEP being for very high risk individuals. However, most programs permit entry if a single engagement of condomless anal sex has occurred in the last 6 months. So really, we're equating any anal condomless sex as high risk, and that is stigmatizing those individuals. Patients with many partners will feel targeted. They may feel shamed. It may lead to disengagement with care. And there is this obsessive focus that we have on risk compensation, that we're actually going to lead to more transmission of sexually transmitted diseases, more transmission of HIV. And we need to make sure that we're talking not about unprotected sex, because what we're seeing with PrEP is that it is protecting you against HIV rather than using the term condomless sex. And we have the problems with our press, and we need to make sure that this kind of headline doesn't lead to fake knowledge within our populations. NHS told to give out 5,000 a year lifestyle drug, i.e. PrEP, to prevent HIV, as vital cataract surgery is rational. You know, it makes no sense at all. And actually, if you look at society as a whole is very much behind PrEP. This is a study which was in the BMJ Open a couple of years ago, looking at what the society felt as regards where public funding should be used. And they looked at 3 diseases, HPV, diabetes, and HIV. And you can see, if we look at the control groups, actually, they're very, very similar as regards public support for funding for PrEP, diabetes, and HPV vaccine. However, when you come and control for lifestyle, i.e., if you come and say, if individuals did this or didn't do this, then there was a lower risk. So for diabetes, losing weight, looking at diet, you can see these drop-offs actually when society is reminded about the lifestyle changes for diabetes, for HPV vaccine, but interestingly, not for PrEP. So forget about those headlines and about what newspapers say. Actually, society is very behind PrEP. So if we come and look at the effect of stigma, stigma actually affects everything that we're trying to achieve. It's going to affect all of our 90-90-90-90 figures. It's going to affect our ability to diagnose, to link into care, to keep those individuals in care, to actually get them on treatment and to remain virologically suppressed. Really, 90-90-90 is over. We can achieve all of those, probably 100, 100, 100, if we can remove stigma out of the equation. And that's at a population level, but also think of the individual who is being stigmatized. This is just one meta-analysis showing the association of stigmatization with depression. So as we stigmatize populations, we see that we get less success, but it also affects the individual in front of us. So what is stigma? Stigma is about all of us, and therefore it's up to all of us to try and deal with stigma, which continues in the HIV population. Thank you very much for listening.